I have to say it's wonderful to be back, and actually it's really nice to be able to put the Irish flag on a slide that says Wales, because it is my second home. I was somewhat surprised that people let me back in, actually. I felt as if I should come into the summit with a balaclava and a little bit of disguise, having seen somebody in Northern Ireland last week who told me that they'd spent about 5 years avoiding me when I was here, so I hope I wasn't quite that bad. So I've been asked to talk about, the title says Getting It Right, which is a really nice title, but actually what I'm going to talk about is health and sustainability. Much of what people have said already, and Francesca, I'm not going to repeat a lot of what you've said, but it really, for me, if I've learned anything in the last 3 years in a public health role, this isn't about the sustainability of a healthcare system. This is about the health and sustainability of a society. And what I mean by that is it's about societal health. And actually, healthcare, so HSE, colleagues in private sector, NHS, only accounts for about 10 to 20% of the overall impact on health and well-being in a country. So when policy solutions are all about chuck more money in the healthcare system, make it more efficient, just squeeze out and sweat out more assets, why are we surprised that we just continue to be on the treadmill? So what I want to talk about is a little bit of a dip into Wales on a demographic perspective, not for too long, you'd be pleased to hear. But the reason I'm doing that is that I think there's quite a lot of consistencies from an Irish perspective and a Welsh perspective, so you'll get a little bit of flavour of that. And then I want to talk about 4 examples of what we're doing in a slightly different way to try and improve health and well-being in Wales. And I mean a very different approach around holistic improvements and embedding it in society. So this is us in Wales today. I'm sure you could put the same slide for Ireland and just change the names, but this won't surprise anybody. On the left-hand side is 2014. As you look, on the right-hand side is 2039. That's that beautiful dotted line of our successfully aging, which would be us, I'm sure, through up for the 85-year-olds. The next line down is the 65 to 84-year-olds, and what's really worrying, which is what Francesca was just saying, is the 2 lines at the bottom. And what that translates to, growing old, great, I'll come back to the healthy extent to which we're growing old, but not enough children being born to offset the tax-paying status for us in a country that is based on social taxation in the NHS and a part mixed public and private for Ireland. And that's assuming that actually we're quite healthy and we can contribute to society as we get older. So bringing this perhaps a little bit more wide, this is a Eurostat slide back in 2015. So it's showing the different age blocks all the way through to 90 plus. And if you look at the dark cerise, obviously pink for the girls, blue for the boys, very sexist comment, the dark colours on each are 2013. And the light colours on each are 2060. So if you just look at that shape, a few people have said this morning about the changing of the bell curve. But what that equates to is about the under 19 stay about the same, the 20s to 64 reduced by about 10%, the 64 and above increased by 10%. And what's really worrying is the number of people at 90 will equal the number of people at 19. So what we've been saying, and you've heard, particularly from a cost effectiveness and an economic perspective, this isn't about an NHS, an HSE, a healthcare challenge. This is about a fiscal and economic challenge about the viability of a country. Based on our assets, bit of natural resources, but our population, we actually need people to be as healthy as they can. And chucking money after the fact is really not going to make any changes. So I'm not going to dwell on this too much, but just to give some currency to this. This is which I think is a fantastic slide. This is a slide that Fitch produced, and it's actually based on OECD data. There's a smile on Francesca's face, she recognises this. It's based on OECD data, and this is about Australia. So really similar. I don't know if there's any Antipodean colleagues in the audience, but on the left side, I'm sure, sorry, at the back you may not be able to read this, but it's looking at the number of Australians aged 65 or older relative to the number of working age people. So back in 2014, I think it was 20%. Predicted, as I've just shown, 2050 will go up to 39%. But more significantly is the stuff on the right-hand side. So that's looking at the increase in Australian public debt relative to GDP. So debt relative to GDP as a consequence of the aging population. So by 2020, that's 4.4%. And if nothing was to change, by 2050, it would be 144.6%. The solution to that is not just continuing to chuck money at a healthcare system. This is about radically changing the health and well-being of a nation. So quick back to Wales. I will move on from Wales in a second around demographics. But our team, we've got fantastic people, really lucky in our organisation, have just done a refresh of the school photograph of Wales around our population and have done some predictive forecasting of what's going to play out if we don't do anything differently. So this is looking at the number of people with 2 or more illnesses aged 16 plus and over, and the relative age groups at the bottom. So 2015, 60% of our population of 75 or more had at least 2 long-term conditions. 50% of our 60-year-olds had at least 2 long-term conditions, and that trend is increasing. Ignore the stuff at the bottom. This is a statistical caveat that our geeks put in. I don't understand it. This is really worrying. Just to set the scene here. So what this chart is looking at is the right-hand side, just at the X and Y. That's 2015. So all that's gone, the state of health in 2015 is below that line. So what this is looking at is a number of conditions additional to today in our population going through to 2035, so 18 plus. And what you see at the top line is the additionality on top of our burden of ill health today for people with stroke. The next line down is people with heart disease. The next time down is people with life-limiting conditions, and then diabetes. Those are the 3 of the 4 biggest killers. So look, we know all this, and there's people keep saying to me, so what the hell do we do about it? And I'm going to come on to a little bit about that in a minute. So this isn't about annualized operational plans that we all do. If you're lucky, you get a 3-year planning. This is about a 20, 30-year policy change, political courage that says, actually, we're going to be bust. Because whatever we're doing, it's not a case of doing more of, because all we're going to be doing is just continuing on the treadmill, and we'll run out of money very quickly. The final bit of the demographic is this. Someone mentioned this earlier. So I could run slide after slide after slide on this. It looks far more complicated than it is. So this is looking at healthy life expectancy and life expectancy. So men at the top, women at the bottom. I'll just focus on the men because the principles are the same. So the top bar we've got is life expectancy. And the top one, it says 77, is what we were like in Wales, 2005 to 9. The one just below it is 2010 to 14. And healthy life expectancy is the number of years living with good health. So I mean, it's great. It's all going in the right direction. We're living longer. Fantastic. But what's really worrying is the little circle on the right. So those tiny little purple lines, I don't know if people can see that at the back, are the difference in an area of healthy life expectancy and life expectancy in Wales in 2015 in an area of high deprivation compared to an area of low deprivation. So we've got about a 19-year gap for us, which is just appalling. And across the UK, we're probably one of the worst. There are different pockets of some real challenge. So whatever we do in trying to address some of the challenges of today, we've also got to actually reduce the inequalities. Because there's, as I said, I can show slide after slide, which is what I call the stepladder of inequalities. Cancer survival, mortality incidence, alcohol, smoking, emergency admissions. We're ignoring that. So how do we really try and do an approach that tackles and reduces inequalities in some of our challenging areas? So as I say, to me, this is about health and sustainability, not how do we make a healthcare system more sustainable, because we've kind of missed the point if that's what we're focusing on. So I want to give you 4 very quick examples, because I'm waiting for Bill to give me this 5-minute sign. Thank you, Bill, when I know I've got 20 minutes left, but he won't mind. He'll just let me get... No, I won't. So 4 very quick examples, and apologies for rushing through this, but I am hanging around afterwards if that helps. So in relation to healthcare, having said all that, of course healthcare is fundamental, because we've got to be able to be as efficient and effective in treating people of today who really need to be kept as independently living as possible in the communities, hopefully. So we have a thing called Prudent Healthcare that was born in about 2014 by an organisation called the Bevan Commission. These are really basic stuff, but we don't do the basics well. We just try to overcomplicate. So there's about 4 principles. professionals and public as equal partners, care for those with the greatest need first, do only what is needed. If I'm a doctor, why am I doing everybody else's job? Just do what actually only I can do. Let's diversify with our workforce in a way that's more cost effective and embraces technology as an adjunct. And make sure we reduce inappropriate variation, particularly where it's causing harm. Seems really obvious, doesn't it? But actually, we're really not embedding that in the way we're running health system. I'm not going to go through this, but the kind of things we can do when we've got 3.5 million people, get them in a room together and really start to drive through the health leaders of the system, is say, what are the 3 things that we could really focus on from a prudent healthcare perspective that we can all do that start to galvanise impact? So there's 3 main areas for us. Antimicrobial prescribing, obviously, around reducing variation. We've got terrible stuff in Wales around antimicrobial variants. We think outpatients, what on earth does outpatients mean? Out from what? One of the most inefficient, ineffective processes in healthcare, I would suggest. So we're looking at how do we really transform outpatients, how do we use technology in a way, how do we realise that patients, if they don't have symptoms, they actually don't need to go for follow-up. You know, they are adults, many of them, or they're an adult of a child. And finally, falls prevention. So falls contribute to significant extensions of days in hospital when the person didn't need to go in the first place. So falls, and I'm going to start to get this thread now in the next 13 and a half minutes. We can only tackle falls by working with Post Office, working with fire and rescue, working with housing, working with the NHS. So this is a cross-system task force around falls prevention, which is just gaining amazing traction. And the people who are really good at it is fire and rescue. They'll go into a home, because actually they've put themselves rather successfully out of the business most of the time. They've still got a community prevention statutory requirement. They'll go in, they'll have a look. An elderly or a vulnerable person, they're trained up around brief intervention as well as a few other things. And they will hand off to social services or local government if there's a problem. So these 3 things, how do we become far more prudent in how we run health systems? The next 3 examples I'm going to give are much broader. So hands up, who's heard of the United Nations Sustainable Development Goals? Snappily titled. William, that hand really went up proudly there, didn't it? So basically, from a UN perspective, with our changing demographic population, with our challenges around sustainability, the focus for the next 15 years is actually about the world addressing the challenges of the world, from health inequalities, global threats, to access to sanitation, etc. And every member state is going to be held to account to that. So amazingly enough, in Wales, we produced a piece of legislation, which is really the main show in town now across all public services, called the Wellbeing of Future Generations Act. This, as a former health minister said to us, is that we cannot continue to mortgage the health of our future generations by paying all of our money today. So this is really about what we do with all the money we have from and I'm looking at most of us in the audience, we have responsibility of spending money. So we have 7 goals, which are really about transforming a country, looking at a prosperous Wales, resilient Wales, healthier Wales, more equal, Wales of cohesive communities, etc., etc. But most importantly, there are 5 principles, so that when we're spending money, when we're making decisions, when we're developing strategies, if we're local government, if we're housing, if we're police, if we're NHS, they've got to be long-term, about prevention, integrated with wherever it's appropriate and whoever it's appropriate to do so, collaboration, involvement. And what that really means now is that we're starting to bring together governing entities, cross-sector, doing their own joint wellbeing self-assessments, trying to address funding of need in their communities in a way that they're sharing assets, sharing funding, which is a really interesting space to be in, and then implementing improvements using 2 or 3 of the interventions that we know is going to transform a nation, which I'll come on to. So this is a really exciting act, and quite frankly, we just have to implement it. Early days, but that, to be fair, is a policy cross-government that says, can't keep putting money into different public services. How do we invest in the future of the nation? The next example, very quickly, for us is, if people have heard of the phrase health in all policies, that isn't healthcare for the NHS. That is health in all policies. Active travel, transport, sustainable development, communities, housing. So we've been, as a public health body, we've been trying to work out how do we influence different secretaries of state, ministers, cabinet secretaries to realise that everything they do will have an opportunity to keep people as our assets as healthy as possible because of the vested interest. Can send people the link on this, but the team have done, looked at all the available evidence and come up with 10 prevention interventions that were the public health manifesto for the new Welsh Assembly government. These were, if Arnie's still in the room, I said to the team, don't want 350 pages, just want to know what the issue is, what the evidence is, what do we know works, and what will be the return on investment, because that's really what gets our politicians tweaked. So given an example of the kind of thing here, the second difference is instead of the 350-page report, we've presented it as an infographic, so that it was really easy for people to understand, as I know yourselves are doing. So, for example, early years, what are the issues? What do we know works? So even down to, so for example, every pound invested in an early years intervention returns up to £16.80. Looking at investing in targeted interventions in early years could save 72 billion over 20 years. So how do we start to shape health and all policies across government to do that? And finally, Bill, he's going like that now. And finally, probably I should have put this at the beginning, our team did a piece of research in Wales about adverse childhood experiences, or ACEs. I don't know if people have heard of ACEs. And we've produced 3 reports, having done research on a couple of thousand people. What ACEs are: verbal abuse, physical abuse, sexual abuse, children who are in a home environment where there's parental separation, domestic violence, incarceration, etc. We have 14% of people in Wales that have 4 or more ACEs. Now, without understanding it, you may say, well, what does that mean? Well, the research evidence for us, but also a lot going on in Washington, a lot going on in Australia. We're working very closely with some of your colleagues and colleagues across the UK, that people with 4 or more ACEs, 20 times more likely to be incarcerated, 15 times more likely to have committed violence against another person, 6 times more likely to have underage sex, 4 times likely to be a high-risk drinker. So we know all this. And these are the kind of kids who go to school and they're seen to be playing out. So they put in detention. Makes them worse. There's shit happening at home. They drop out of school. They find it really difficult to get a job. They get into high-risk taking behaviours. They end up in the police. If they're lucky, they may not be in prison, but they'll start to have problems with mental health. They'll start to have problems from a healthcare perspective. There are only 2 slides left, Phil. So the study we were looking at is saying, well, through the lens of mental health then, for people who've had 4 or more ACEs, what does that look like? Well, this is people self-assessing themselves around mental health, and Alistair's presentation this morning was fantastic. People with 4 or more ACEs are 3 times more likely to have felt low well-being, low self-esteem, and I won't go into the detail, but these are statistically significant figures that are playing out, probably more relevant for today. And finally, the third phase of the study, we've got another one going on, is looking at the relationship between ACEs and healthcare utilisation and healthcare presentation. So up to the age of 69, those with 4 or more ACEs are twice more likely than those with not to be diagnosed with chronic diseases, 4 times more likely to be diabetic, 3 times more likely to have respiratory disease, and are 3 times more likely to have attended an A&E in the previous month that we engaged with them. The key issue about this is actually we can do something about it. So what we're saying with colleagues is this is about criminal justice, this is about housing, this is about education, this is about the health. This is the Trojan horse that transforms the health and the cost and the expenditure of a nation, as far as we're concerned. So we've had 3 cross-government departments funding a whole ACE hub. We've got stuff happening in housing. We've got an all-Wales bid going in from all of the police forces, police and crime commissioners, to UK government for a completely ACE-informed police and criminal justice system. The single most important issue of it, though, with all of the studies, is that one constant older person that's there for that child's life that makes a significant impact. So we're training up teachers, we're training up all public servants to be ACE aware, and then we're remodeling so that someone can catch that child, provide that support, and hopefully when you looked at that chart of all this redundant money and this redundant ill health and early death, we can start to change, and the Wellbeing of Future Generations Act is the best way to do that. Finally, if you want to know more about it, there's a really, really good video, www.aces.me.uk, which is quite emotional, but it's something that I think everybody needs to read about ACEs because it's happening all around us. Thank you very much.